Hi and welcome to my podcast, Gut Health Nurse. I'm going to read you a few symptoms here in a moment, and I want for you to count in your head how many of them you have, because I think you are going to be surprised. I'm your host, Kamisha. I've been a registered nurse for over 10 years, and I too had issues with hiatal hernia, GERD, gastritis, bloating, acid reflux, you name it. And so I wanted to share some of the things I learned along my journey. Part of me doing this podcast is to bring some clarity to this condition and surrounding symptoms, because a lot of these symptoms sometimes are not things that you would typically associate with a condition at hand, right? But in hindsight, these are some of the very symptoms that I had, and without doing further analysis or getting a better understanding of the condition in itself, it is something that essentially went missed or misdiagnosed for a while before it was eventually caught, right? And so I wanted to share some insight on these so that if you're having these symptoms, you can be an advocate for yourself and to help to get resolution to what you potentially may be going through. All right, so let's dive in. So by the end of this video, you're going to know every symptom connected to hiatal hernia, the typical, atypical, and the ones that most commonly gets misdiagnosed. You're also going to know what to do when your symptoms are dismissed. So most people with hiatal hernia, they know about heartburn. Maybe they even know about reflux, but that's not the full picture. It is so much bigger. And when symptoms are unrecognized, patient can often end up in the wrong specialist office for years. I've seen it happen. In fact, it has happened to me. And by the end of this episode, you're going to understand exactly why that happens. So hiatal hernia is often called the great mimic in some clinical setting. Its symptoms look like heart disease, anxiety, asthma, and ENT conditions. I'm going to explain to you about the Roemheld Syndrome. It's also called the gastrocardiac syndrome. So in this section, we're going to look at why symptoms matter more than diagnosis. So for many people, maybe even the majority, you have a hiatal hernia and you feel nothing, right? No symptoms at all. And sometimes it even shows up on an endoscopy that is done for something entirely different. And so the doctor may say, oh, as if, by the way, you also have a small hernia, almost like a footnote. But hernia presence doesn't automatically mean that you have symptoms. The size and type, the degree of the LES dysfunction, and individual sensitivity all affect the picture. Sliding hernias are often asymptomatic. Larger hernias are more likely to produce reflux or mechanical symptoms. About 50 to 90% of patients with GERD have a sliding hernia. This is an overlapping in percentage. The overlap is significant but not total. Not everyone with GERD has a hiatal hernia, and not everyone with a hernia has GERD. So just wanted to be clear about that. Even the number is that significant, right? Size is one factor, but a small hernia that disrupts LES function in the wrong position can cause significant symptoms in one person and nothing in someone else. The hernia is real, and the variation is also real. In this section, we're going to look at the typical symptoms, the one everyone knows. Let's start with the typical symptom. These are the ones caused directly by acid reflux from a weakened LES. These are the esophageal symptoms most people associate with this condition. First up is heartburn. It's that burning sensation in the midsection behind the breastbone. It's caused by the stomach acid touching the unprotected esophageal lining. Remember, the esophagus does not have that mucus protective lining like the stomach does. Heartburn often worsens after eating, when bending over, or when lying down. It's often at times worsen at nights too, and gravity no longer helps keep the acid down. So for heartburn that happens more than twice a week, this warrants investigation. And not just, brushing it off as, I just have heartburn, right? By just making that statement of, I just have heartburn, that is one of the most common forms of normalizing something that needs addressing. So another symptom is acid regurgitation. And for this, you have the stomach acid or food rising back into the throat or mouth with a bitter or sour taste. This can happen without that classical feeling of having a burning sensation. So for regurgitation that persists even when you're on a PPI, this is a sign of mechanical barrier dysfunction, where it is the hernia itself that is causing or adding to the problem and not just acid. If your medication reduces heartburn but the regurgitation persists, tell your doctor specifically about that. The distinction matters for the treatment decisions that are made in your case. The other symptom or typical symptom is that of dysphagia or difficulty swallowing. That sensation of food being stuck, particularly solid foods. Food may ball up in the lower esophagus until it passes. But it's not always solid foods that happens with. Sometimes it occurs with liquids in cases that are more severe. If you have new dysphagia or dysphagia that's worsening, it's always best to err on the side of caution. You never want to dismiss it as just you having a hernia, because God forbid you don't want for it to have advanced to it being Barrett's esophagus or you having a stricture. All right, so I want to emphasize this. Dysphagia is an alarming situation. It's an alarming symptom. Never dismiss difficulty swallowing as just part of you having a hernia. It warrants prompt investigation. Another symptom that's often associated with a hiatal hernia, or one that's more typical, is that of having early satiety or indigestion, meaning feeling full very quickly after eating, even when you eat small meals. Bloating and discomfort are often a part of it as well. This is often accompanied by burning abdominal pain. This is more common with paraesophageal hernias, where the stomach position is mechanically altered. And we have the other set of symptoms that involves burping and belching. You have excess gas and frequent burping, especially after meals. Sometimes the only noticeable symptom are these two for months before anything else develops. This is typically related to swallowing of air or aerophagia and the disrupted gastric function. And then we have the atypical symptoms, the ones that typically gets missed. So now we get to the part that I think is most valuable, because these are symptoms most people have never connected to their hiatal hernia. Again, these are symptoms that many people have not connected to their hiatal hernia. These are the ones that lead to misdiagnosis, the ones that led to anxiety medications that didn't help, the ones that led to cardiologists and ENT specialists when the answer was in the gut the whole time. These are called extraesophageal or atypical manifestations. They occur when acid or inflammation extends beyond the esophagus, or when the hernia creates mechanical pressure or vagal nerve disruption. This often occurs without the classic heartburn, which is why they're often missed. So usually hiatal hernia is associated with you having heartburn of some sort, right? But when you're having all these other issues and you have no heartburn, the last place that's usually thought of is that it's related to your gut or your digestive system without that heartburn feeling, right? So the first symptom in this category that we're looking at is chest pain, non-cardiac chest pain. It can feel identical to cardiac chest pain, the crushing pressure that's radiating. So this chest pain is caused by acid touching the esophagus, which shares the same pathway as the heart, or a mechanical pressure from the hernia. So this is called the non-cardiac chest pain because it is recurring chest pain that feels like angina, but it isn't. I want to be very clear. I said this in my previous video and I'm saying it again. If you have chest pain or cardiac causes that have not yet been ruled out, that is your priority, right? You want to get that done first. It's better to be safe than sorry. But if you've had a full cardiac workup and everything comes back as being cleared and you still have the chest pain, your gastrointestinal system is absolutely worth investigating. The esophagus and the heart shares a nerve pathway. The pain can be indistinguishable, right? So if you've already had your clearing from a cardiologist, but you're still having these symptoms, it is very much so, worth you getting your gastrointestinal system evaluated to see if this has anything to do with a hernia. The other symptoms associated with having a hiatal hernia are the atypical symptoms of heart palpitation and arrhythmias. You get that feeling as if your heart is skipping a beat, right? That fluttering, that racing and pounding. It's caused by irritation of the vagus nerve, which runs close to both the esophagus and the heart. When acid touches the esophagus, it can trigger a vagal response that directly affects the heart. The hernia itself can physically compress and stimulate the vagus nerve, especially with larger hernias. This connection has been made the Roemheld Syndrome or gastrocardiac syndrome, and we'll cover this fully at the end of this video. There are clinical documentations of cases that exist involving cardiac arrhythmias that fully resolve after a hiatal hernia repair has been done. The palpitations are real, but it was not the anxiety that was causing the issue. It was the gut that's affecting the heart by way of the nervous system. The other atypical symptom is shortness of breath. And the mechanism for this involves one, physical compression, meaning you have large hernia that reduces the thoracic volume and mechanically compresses the lungs. Then you have mechanism number two, which is diaphragmatic dysfunction, where the hernia disrupts normal diaphragm movement and affects breathing mechanics. Oftentimes this has to do with exertion, meaning it worsens with activity or after a large meal. Something else that can also cause shortness of breath or dyspnea is large paraesophageal hernias, which compresses the left atrium. The other atypical symptom is that of having Globus sensation or the feeling of lump in the throat. So this is a persistent feeling of having something stuck in the throat even when there's nothing there. It's not a physical lump. It is inflammation or irritation from acid that's reaching the upper esophagus and the throat. It's often worsened when you're swallowing saliva, but it feels better when you're eating because food can temporarily neutralize the acid that's present. This is frequently misdiagnosed as anxiety or a throat condition or dismissed entirely. So globus is one of the most distressing symptoms because it's constant and because there's nothing there. When basic examination is done, there's nothing that's found, and patients are often told that it's psychological. Well, it's not, right? It has a clear physical mechanism to it. The other atypical symptom has to do with chronic cough. A dry, persistent cough that doesn't respond to typical cough treatments. This is caused by acid microaspiration into the airway or a vagal nerve irritation triggering a reflux cough reflux. This is often worsened at night and frequently attributed to one having asthma, postnasal drip, or allergies rather than reflux. A point to note is that chronic cough is associated with GERD in about 21 to 41% of cases. And that's a significant portion when you think about it. Another chronic condition that is atypical and associated with hiatal hernia is that of having chronic laryngitis or hoarseness. Hoarseness or rough voice, especially in the morning. This is caused by the acid reaching the larynx and causing inflammation. This is typically referred to as laryngopharyngeal reflux or LPR. This is also often attributed to the overuse of the voice, viral infection, or allergies. Another way that this often shows up too is in dental documentation, where there is dental erosion on the lingual and palatal surfaces. And this is from the acid reaching the mouth during the hours of sleep. Another atypical condition is, or symptom, is that of nausea, right? So this nausea typically occurs after eating due to compression of the stomach or acid overflow, right? And this at times is perhaps the chief complaint that you have, right, with this. This is particularly associated with the paraesophageal hernia. Oftentimes, though, this is assumed to be a separate gastrointestinal issue, something relating to anxiety or signs of early pregnancy. And another symptom we touched on briefly in the other podcast is that of having back pain between the shoulder blades. Now, this back pain is what's referred to as referred pain. This pain radiates from the esophagus, the stomach, or the diaphragm. It's a dull, aching discomfort between the shoulder blades or mid-back. Now, frequently when investigation is done regarding this, it's generally in terms of evaluating the musculoskeletal system through physiotherapy, chiropractic assessments or interventions without the GI connection being made for that, right? But that is something that can too be related to hiatal hernia. So moving on to the next symptom, we're going to be looking at sore throat and chronic throat clearing. Now, this is caused by irritation of the posterior pharynx. And in this, you have frequent throat clearing and attempts being made to clear a sensation of acid or mucus. Now, this is frequently associated with the sensation that you get when you have postnasal drip. It's often treated with antihistamines when the cause is reflux. Another atypical symptom is that of having sleep disturbance, right? So nocturnal reflux when lying flat disrupts the quality of your sleep. And the frequent waking with burning, coughing, or throat irritation is something that typically happens throughout those times that your sleep is disturbed, right, or disrupted. So, chronic sleep disruption often worsens your overall symptom. And what this looks like is poor sleep, which elevates cortisol, which worsens or reflux even further, right? The sleep reflux loop is particularly important for nurses and moms. Why? Because shift work disrupts sleeps, raises cortisol level, worsens LES tone, worsens reflux, then the reflux disrupt the sleep even further, right? And especially for new moms or moms in general, if you have children and your pattern is interrupted in a similar manner, then that too can add to the issue, right? So it compounds nonetheless. And this is one of the reasons the condition is hard to manage in high stress, sleep disrupted people, aka nurses and moms, right? Especially nurses who work the night shift. Um, yeah, that's a whole different topic. So now let's dive into why hiatal hernia is called the great mimic. There is a reason this condition is called the great mimic in a lot of clinical settings. And I want to talk about it directly because it's the reason so many of you, including myself, spent a lot of years in the wrong specialist's office. Hiatal hernia can mimic cardiac disease, right? With you having chest pains and palpitation. It can mimic anxiety disorder with palpitation, breathlessness, chest tightness. It can mimic asthma with cough and wheeze. It can mimic ENT conditions like laryngitis and sore throat. It can also mimic musculoskeletal problems like back pain and chest pain, which we discussed previously. Now, many patients receive multiple diagnoses that's done before the GI connection is made. So you're diagnosed with all these different conditions, and a lot of time the connection is not made to the issue having anything to do with or originating from the gastrointestinal system. As a nurse, the first thing I do when I encounter or interact with someone who has been having unresolved condition is to investigate how their gastrointestinal system has been functioning. Because oftentimes, though it's a question that should be asked, it's one that's usually not asked. And therein usually lies a lot of clues to how things can be rectified. It should be one of the first questions asked, but that's often not the case, right? So, what to do when symptoms are dismissed? I want to talk directly to anyone who has been dismissed, who has ever been told everything looks fine when nothing feels fine, who has been given anxiety medication when what they needed was a GI workup. This section is for you. Your symptoms are real. Every single one has a physiological mechanism, even if it's not yet been found. Being dismissed is not evidence that nothing is wrong. It's evidence that more investigation is needed. So I want to share 5 practical tips with you if you've ever been dismissed or if you've been, going around in circles trying to figure out what's going on. Number 1, keep a symptom diary. You want to include date, time, what you were doing, what the symptom was, how long it lasted, and what relieved it. Pattern recognition is everything in GI medicine. Number 2, use specific language at appointments. Don't say, I feel off. Say instead, I have a burning sensation in my mid chest after eating that lasts about 30 minutes and it's partially relieved by sitting upright. When you're specific, things get investigated. If you bring vagueness, you'll get reassurance. Number three, specifically ask for a GI referral if one has not yet been done. Ask for a gastroenterologist referral. Ask specifically for an upper endoscopy to rule out structural GI issues. Make reference to a hiatal hernia if you've been previously diagnosed with one. You want to reference that as well. Number four, bring someone with you. A second person in the room changes the dynamic. Symptoms are taken more seriously and the conversation is more thorough. Number five, seek a second opinion if needed. You're entitled to a second opinion. Use it if your symptoms are significantly impacting your life and you're not getting satisfactory investigation. Use that second opinion. So this is for nurses specifically and for moms. We are often our worst advocates. We know enough to self-diagnose stress or anxiety. We attribute everything to work. I see you. Your GI symptoms are worth investigating as much as any patient's. And for moms, you're typically busy taking care of everybody else excepting for yourself. Do not delay investigating your symptoms. You're just as important as your family. And now we're going to talk about Roemheld syndrome. This is also called gastrocardiac syndrome. It's a condition where gastrointestinal problems cause cardiac symptoms through the vagus nerve. In patients with hiatal hernia, the stomach pressing through the diaphragm physically stimulates or compresses the vagus nerve. That nerve controls your heart rate, so your GI system is directly affecting your heart. The palpitations are real. The skipped beats are real. It's not anxiety. It's your gut affecting your heart through the nervous system. And when the hiatal hernia is treated, the cardiac symptoms often resolve. Think about that. So for you who are listening, which symptom on today's list surprised you the most? Which ones are you dealing with that you never connected to your hiatal hernia? Tell me in the comments. I do read all my comments, and your comment may just be the one I make my next video about. I do have a free hiatal hernia starter guide in the description. You're welcome to grab that. In the upcoming episode, I will be talking about foods to avoid and those to include. And this is not your basic list, so you're going to want to tune in for that. If you found this useful and want to keep getting clinical education, be sure to like, comment, share, and subscribe. And if you know someone who's been dealing with issues and they haven't really fully gotten their situation resolved, send them this video. It may just be the video that they need to help connect the dots and solve their issue as well. All right? Thank you for tuning in. Thank you for tuning in, and I'll see you in episode 3.